I'm Ahmed Abulaban, MS neurologist at King Abdulaziz Medical City. I have with me my colleague, Dr. Yasser Al-Malik, as well from the same institution. Hello, everyone. I'm glad to be with you here today. Our topic for today is the role of pharmacoeconomic in decision-making at the institutional level for specialty drugs. The learning objectives is to compare and contrast how pharmacoeconomics are used to make listing decisions at the hospital institutional level. Also will explain how cost effectiveness threshold inform drug policy listing decisions. We are going to discuss the role of private listing agreements. And finally, we're going to explore various options to ensure appropriate prescribing to drive efficient use of pharmaceuticals. Pharmacoeconomics can be used at the healthcare institutional level to make drug policy listing decisions.
That's a great question, Dr. Ahmed. There are several factors that come into play. So we're talking about drug efficacy, the safety, patient preference, etc. And the process of drug evaluation include the development of a scoring tool that includes several factors, including the body of evidence, as I've mentioned, the efficacy, safety, the cost impact, the patient preference is also important, as well as the availability of other medications in the formulary. The pharmacoeconomics data are also important in the P&T decision-making process. There's a recent study from Saudi that looked at, it's a survey that looked at more than 11 pharmacy departments here in Riyadh, Saudi Arabia, and about 75% of respondents indicated that they've used pharmacoeconomics in their decision-making process, and about 80% indicated that they have fair knowledge about pharmacoeconomics. However, more education, I think, is needed for the decision makers to improve and facilitate the application of pharmacoeconomics data for drug listing decisions. Yes.
So one of the things is you see some medications get approved in some countries and not approved in other countries. So that's depend on multiple factors. It's a complex decision and evaluations stream. And do you think how they look into the effect size of the medication? Do you think they take this into account, or how they evaluate this?
So here I think they're going to look at the cost effectiveness data. So the cost effectiveness threshold represent what is expected to be giving up in order to implement a new intervention or to have a new medication. And this will help the decision makers to determine if a particular medication or intervention represent an efficient way for health resource allocation. There are commonly cited cost effectiveness thresholds between $20,000 per quality to $50,000 per quality, but it's largely really, as you mentioned, depends on the jurisdictions and the policies of the payer. Now, for rare diseases, they use a different kind of variable, would be something called incremental cost effectiveness ratio, which can be very high, more than $100,000 per quality, which has a total limited impact on the budget, especially for very low prevalence diseases. Yes, Ahmed.
Yeah, so the outcome also and the population is different from country to country. You might find the same medication but approved for different indication in different countries. So the whole process is complex. It's not similar in between different big bodies. So this takes me to the next question. How are cost effectiveness thresholds used when making drug policy listing decisions?
As I've mentioned earlier, cost effectiveness thresholds represent what is expected to be giving up, or what is known as opportunity cost, in order to implement a new intervention and its associated cost. This threshold helps decision makers to determine particular intervention represents an efficient allocation of resources. As I mentioned earlier, commonly cited thresholds include $20,000 per quality or $50,000 per quality, but again, it's largely dependent on the jurisdictions and policies of payer. Looking at multiple sclerosis as an example, fingolimod, which is one of the oral disease-modifying therapies for relapsing MS, a 2020 study compared fingolimod to interferon beta 1A for treatment of pediatric onset multiple sclerosis in Canada. The incremental cost effectiveness ratio, or ICER, was $20,000 per quality. And based on the assumption that $50,000 per quality as being cost effective for new medicine. Again, as you see in this example, the cost effectiveness threshold depends on the jurisdictions and the policies of the payer. Yes, Ahmed.
Yeah, so we are starting to see some data to suggest use of moderate or high efficacy treatment can change the outcome, and this will impact on the decision making and the evaluation of medications for different indications. For example, in the in multiple sclerosis, the clinically isolated syndrome versus multiple sclerosis, relapsing remitting or primary progressive or secondary progressive, and we'll see some changes in the near futures, maybe in the clinical criteria, if the some of the evidence showed that treatment also for radiologically isolated syndrome can impact the outcome. What role, if any, do listing agreements play in drug policy listing decisions?
So private listing agreements are entered into a secure reimbursement for high cost product. They can also be used to avoid managed access mechanisms to drugs. For example, in Canada, since 2015, private listing agreements have significantly increased. The manufacturers are more interested in private listing agreements for product costing more than $50,000 annually, and payers target drugs priced more than $10,000 annually. For high cost drugs, especially biologics therapies, they are often a condition of drug listing. Do you have any experience, Dr. Ahmed, for the PLAs in Saudi Arabia?
One of the things from my experience as working in the drug sub-evaluating committee in our hospital, the process is complex, and it dictates in the meeting with many experts in the field, from the pharmacology and also from the pharmacoeconomic expert and one expert in the field, and we discuss different topic about the medication of interest. And this approval is very important because we work as a governmental hospital, and once the medication is approved, it will be prescribed by all the physicians, or sometimes we put restriction to certain subspecialty. This evaluation is complex, and it will take voting mechanism after understanding the mechanism of the action. Is there an alternative to that? How many patients do we have? What's the cost per year? What's the cost of the medication? Is it gonna make an impact on the healthcare system? Is there a difficulty in the administration or monitoring for the patients? All these factors will be taken into account before making the decision whether or not to approve the medication as a recommendation from this committee. And then we have different committee that will revise the recommendations and will make different revisions and make the final decision. Because as working in a governmental hospital, once you have the medication approved, it will be provided by the institutions, and will not go through insurance or other parties. So it will be just available for prescribing for any patients who needed that medication. Dr. Yasser, is there a mechanism to ensure appropriate prescribing to drive efficient use of pharmaceuticals?
So if you look in North America, there are various strategies that have been implemented to improve prescribing for maximum or to maximize the efficient allocation of healthcare resources. So some of these strategies include clinical practice guidelines, which is informed by systematic reviews to optimize patient care, use of protocol drive prescribing as a standard order set, academic detailing of prescribers' rule, and if so, its utility. And I think we have similar experience here in Saudi, Ahmed, in terms of prescribing or protocol driving prescription. What's your experience in Saudi Arabia?
So there are certain mechanisms that can help about making sure about the efficient use of pharmaceuticals that include regional and national guidelines and monitoring of the data through registry can help ensure good clinical practice.
Very good. Thank you so much, Dr. Ahmed. Okay, Dr. Ahmed, there are more recently quality of care indicators have been investigated in MS. Can you please elaborate on those?
One of the most important indicators is early onset of disease-modifying treatment. As we know that earlier treatment result in a better outcome, and that's the idea behind changing the clinical criteria many times. And second is the patient's development of symptoms or worsening of symptoms. Is it a relapse? Is it a pseudo relapse? Patient need to have an answer to that at the appropriate time, so they can manage their activities. Third, patients need also promotion of their overall health and well-being, including physical exercise. Patients need to have a coordinated multidisciplinary approach that include physiotherapy, assessment, occupational therapy. Patients need evaluation for different tools, needs. Fourth, patients need active cooperations between the physician and patients in the decision process. Patients need to be involved in the care plan and decision making for whatever they need. Thank you, Dr. Yasser, for this wonderful conversation. Thank you, everybody, and wish you all the best. Thank you.
Thank you, Dr.